Thank you for joining us today with the Colorectal Surgery Virtual Education Series. And we'll be continuing our series focusing on the first couple years of practice. Today we have Dr. Nicole Lopez joining us. Dr. Lopez is an associate professor of surgery at UC San Diego, my alma mater. And she is a triple threat. She's board certified in general surgery, complex general surgical oncology, as well as colon and rectal surgery. And she also did additional training in clinical informatics and is also boarded in that. Her interests are focused on caring for patients with colorectal cancers, and she's very skilled both in laparoscopy and robotic surgery. And locally at UC San Diego, she leads the NAPRC Rectal Cancer Tumor Board. Nationally, Dr. Lopez is also involved with the American College of Surgeons Cancer Surgery Standards Program Committee, where she focuses on the colorectal disease site working group, on colorectal diseases. And she also is on the colorectal disease site working group for the SSO, the Society for Surgical Oncology. Within our society, the ASCRS, she sits on the Research Foundation, as well as she's also a member of the Health Economics Committee. And she has spoken in the past and also presented at the annual meeting on billing and coding. And so we invited her to just bring her experience in that space and speak to us on her experience in the first few years of practice, and also just working on billing and coding for colorectal surgeons. We're really excited that you joined us tonight. Thank you so much. And I will pass the mic over to you.
Sounds good. Good evening and good afternoon, everyone. Thanks for having me as a guest. Happy Sunday. I am going to start sharing my slides, so hopefully that'll work. I have called this, Can I Bill for This? And ideally it's a primer for your first year of practice. Nobody ever talked to me about this. I do have some disclaimers, disclosures. One is I'm not a certified billing and coding specialist. And so, take this with a grain of salt. These are just some of the tips and tricks I've learned over the years. And you should really heavily rely upon your billing and compliance teams at your institutions. So just a little bit of history on billing in the US so that you have an idea of where it comes from. It all started in 1965 with LBJ when he started the Great Society, and with that came Medicare and Social Security. And there was a need for some way to uniformly reimburse physicians. The AMA came up with this current procedural terminology system, the CPT, and then in 1999, HIPAA gave some standards for electronic healthcare information and how to include those coding sets. So in 2000, CPT became the national coding standard, and it's a living document, which means that every year the CPT codes are adjusted and rethought out to adjust for new procedures and new techniques, and get rid of things that maybe we don't do any longer. So again, it was brought about by the Centers for Medicare and Medicaid, or CMS. They based the RVU system on a 1988 Harvard study where they got together physicians who worked to estimate what the work was involved for a number of procedures and services. They were authorized in 1989 and implemented in 1992. And even though it's a difficult system to work with, the thought is that it's better than before, because before 1992, services were paid based on billed charges. They were highly variable. There wasn't a lot of correlation to the resource intensity necessary. There were a lot of ways to game the system, and there was not a consistent way across payers to reimburse physicians, and that led to a difficulty of the providers to plan and budget. So RVU, a total RVU is made up of three components: the work RVUs, which is what most people think about when we're thinking about our own reimbursement. That's because we want to know how much we're taking home, but also there's practice expense RVUs and malpractice RVUs. And again, they all contribute to the total RVU. I've put up the percentages there so you can see that work RVUs are a little bit more than half, with practice expenses a little less than half, and almost 4 or 5% in malpractice. Probably one of the first places that we start billing is in clinic. So when we think about clinic, it's changed even in the last 5 years or so, but office visits are divided into new and established patients. And then you can bill based on either the level of decision making or by time. And so here you see the medical decision making. So we have straightforward, low, moderate, and those are broken down the same, and high, and those are broken down the same for new and established. And then the time differences are a little bit different for new and established. And then here I've listed the RVUs. So you can see new patients in general get a little bit higher reimbursement. So when you want to bill by time, you generally, what I do is I put at the end of my note, I personally spent however many minutes in face-to-face and non-face-to-face, because you can count in the time that you did to review either before or after, or write your note or close out the service. But it really does all have to be done within that 24-hour period, or at least that's what the intention is by the billing. So you can't include in that any separately reportable services. So for example, if I spent of my 20-minute visit, 5 minutes doing an anoscopy, I can only say I spent 15 minutes in face-to-face and non-face-to-face activities, because I'm going to bill for that anoscopy separate, and that falls in that separately reportable services. That's a little tricky too, and you have to do a modifier. I think we're going to talk about that a little later, but that's probably the most common time that you have to be thoughtful about your wording and make sure that you put the appropriate modifier. So billing time by time still is the most straightforward way to do it. A little bit more difficult way, but say you have a short visit that dealt with a very complex idea, you might want to bill by decision making. So in a lot of our EHRs, we have a chart like this that can help you decide how you're going to bill. I'd say as surgeons and specialty surgeons, we should mostly be billing in this moderate or high category. And I'm going to show you how you do that. Basically, you want to pay attention to these 4 boxes. The idea is that to get any one of these levels, you have to have at least 2 boxes. So if I fill a high number of complexity and problems, and I still only make a risk of complications at a moderate level, we go to, it defaults to a level moderate. So you go to 2. But if I have 2, say I have a high level of number and complexity of problems addressed, and I also have a high risk of complications, then we bill for high. And you can have any 2 of these 3 boxes. The other one is elements of medical decision making. That includes things like I reviewed the images from prior studies, or I looked at the notes, or I ordered extra tests. I talked to other physicians. So that's what this complexity of data that you're analyzing. So we're going to go over that a little bit here. So looking at this first risk box here in the level moderate, if we want to bill for moderate risk, examples of that are prescription drug management. If you have a minor surgery and the patient has some risk factors, if you're deciding on a major surgery and there aren't any risk factors, or the diagnosis or treatment is limited by social determinants of health. So things that you want to say to indicate or prove that this is your moderate risk. I have prescribed, usually I put this in the assessment and plan. I've prescribed patient risk factors include, procedure risk factors include, and I actually just put that and then I list them out. Or care for this patient is significantly limited by homelessness, or by difficulty getting rides, or they don't have a job, whatever you think the care is limited by. But you really do have to kind of prove that this is your risk. Sorry, going back to then the number and complexity of problems addressed, that's here. To get a high, it's not that hard actually in colon rectal, because most of our patients will fall into this category: acute or chronic illness or injury that poses a threat to life or bodily function. I think many of the problems we see fall under the bodily function, so it's easy to pick this one. And again, this is just kind of how to maximize your billing. It might not always be appropriate. If it's not appropriate, you can't do that. That's fraud. But I think many of our patients with ostomies, patients with um, you know, fecal incontinence, patients with rectal prolapse. I think those are all examples that significantly limit bodily function. So um, I think it's fair to do this. You just have to use the right words to explain it. So somewhere in the context of the note, usually I write something like severely affecting their quality of life or significantly affecting their ability to do whatever. Cancer poses a threat to life. So I just try and list it and make it very clear that that's what I'm supporting. And again, this is if you're going by medical decision making. For that high level of data reviewed or analyzed, this one gets a little bit more complex because they give you 3 categories and you have to meet 2 out of the 3. So because this is harder to meet, I don't usually try and go for this one. But if you're going to try and go for this one, if you want category 1, you have to meet 3 of these combinations. So you have to say, I've reviewed the note from, whoever wrote it on whatever date. I reviewed the results from these tests. I ordered these tests. Or I had to talk to somebody else to figure out what was going on. To get 3 out of those is pretty difficult. And then not only that, but you have to meet another category. So I have reviewed I've reviewed the scans and agree with the interpretation provided, or, you put your own interpretation. Probably the easiest one to get is talking to another provider. But this one, I don't usually use this one just because it's complex to get it and there's lots of different moving parts. And I find that at least at my institution, and with my patient practice, most of my patients have risk factors and probably yours will too. Oh, sorry, my slide is mislabeled. This is high, but this is high risk of morbidity. Again, most of my patients fall into this category. But decision regarding elective major surgery with identified risk factors. We don't usually have drug toxicity, but if you do, then that's perfect. Emergency major surgery, if you're going to hospitalize somebody or you decide not to DNR. This one, the DNR, I don't usually do in clinic, but things that I say are patient risk factors include, again, or procedure risk factors and why, and then we'll proceed to emergency surgery or we'll arrange for admission. And you just have to really use those words to make it clear to your billers and coders that you deserve this level. So again, I think it's pretty easy to use this high number of complexity and problems addressed because of this threat to life for cancers or bodily function for many of the disorders that we see. A moderate risk if they have no risk factors, or high risk if they have risk factors. To me, using this complexity of data that you analyze is difficult because there's so many moving parts. So I don't usually use that, but you can. And then I guess when I do very simple things like hemorrhoids, I usually bill on time because it's harder to get the complexity in decision making.
Quick question. So let's say in your clinic appointment for a cancer patient, you end up having a goals of care conversation and do in fact like have it results in some kind of decision about their code status. Like is that billed separately or is that part of this high complexity medical decision making?
Yeah, the max you can get is high. There are some codes for palliative, for example, that are totally billed separately, but usually I don't use those. Usually I would just say a high because the number of codes that are there to look at those sorts of things are just insane and it's too much for me to think about. But if you have a practice where that's something that you're doing regularly, you would definitely want to look at that as a way to do additional billing. Usually though, I suppose you would count it here as a high because you would go number and complexity of problems would fit in this one, and then that would be your decision to not resuscitate or de-escalate care. And you probably wouldn't be doing too many of these other things or, adding more of them doesn't necessarily increase your complexity. If you're billing for time, there's ways that you can, I can't remember if I have it in here, but if you're billing time, for example, say you spend 60 minutes, and you add another, you actually spend 80 minutes and the max is 60, there's ways that you can increase the time that you spent. So CPT, again, it's a 5-digit code. Probably most of you have seen this somewhere. We live in the 4000s range because that's the digestive system. On occasion, you might do something else like a hernia or any other thing, maybe anesthesia, if you're giving yourself, doing anesthesia for your own colonoscopies. But generally, we live in the 4000s. The first thing that I wanted to talk about in coding was just co-surgeon versus assistant surgeon, because I think this is one that most of us will use at some point and one that totally confused me at first. So co-surgeon is a modifier 62. Generally it's 2 surgeons and you're sharing the same CPT code. So you're both doing the right hemicolectomy, or you're both doing the APR, or whatever. But additionally, you tend to need to do it because of the complexity of the case, and they tend to be surgeons of different specialties. Medicare, I think, won't pay for co-surgery on 2 surgeons of the same specialty, but some of the other insurances will. So you can always try and see if you can get it. And the benefit to trying is that each surgeon gets 62.5% versus in the assistant surgeon, you only get the main surgeon gets 100% and the assisting surgeon gets 16%. So, but again, the co-surgeon is generally, you share one CPT code, so you're doing one procedure together, and you need 2 surgeons there because it's very complex. You don't want to do it when 2 surgeons of different specialties are doing different procedures. So if I'm doing a right hemicolectomy and there's a urologist who's doing a right nephrectomy and we did it together because the patient needed both, we don't bill together. We're not co-surgeons. We're totally separate. It has nothing to do with co or assistant. What do you need to write in your documentation? Both surgeons, if you're co-surgeons, need to write separate operative notes. Generally, both surgeons should document themselves and also the other co-surgeon. In the body of the report, usually I list out which parts somebody else did, or I say that we did them together. And I just kind of try and label in my op note what was done by who as much as possible. That's not that, people aren't that strict about it. I've never had somebody say, oh, you didn't write down what so-and-so did, but officially you should be designated what the other person did. For an assistant surgeon, these 3 codes are somewhat similar in that the reimbursement for the person assisting is relatively the same, 14 to 16% here. And 80 is if a surgeon assists another person. 82 is a surgeon assists another surgeon, but you're in an academic center, so you specifically have to talk about why you didn't use the resident. And then an AS is if you are having an APP help you, so you have a PA or an NP or some other person that's a specialist in surgery help you. So, but they're very similar. Only the primary surgeon writes the operative report. They document who helped them. And then with an 82, you would want to say some reason that the resident wasn't available. Either the resident was busy in other activities, there's not enough residents, the complexity of a surgery required another faculty member, or it was just an emergency. In the body of the report, again, you want to write down who's doing what as much as you can. So just to kind of go through this, a few examples. Gynecologic oncology calls you to take the rectum out as part of a posterior exenteration. So is that co-surgeon or assistant surgeon? This is co-surgeons because it's all part of the posterior exenteration. You're taking the tissue out in block, and so you're doing it together. 2 surgeons doing the same CPT code with different specialties. And again, that's the definition of co-surgeon. Sometimes you can get co-surgeon from your own specialty, but it's not guaranteed, and I think Medicare doesn't specifically pay for it. Next one, you call a vascular surgeon to fix an injury you caused during a colectomy. This one is totally separate. The vascular surgeon is doing something that is not coded for by your CPT code, so it's separate. You don't have to put co or assistant. It's a little different if you fix it for yourself. If you fix it for yourself, it's not billable. And that's because you can't bill for an iatrogenic injury that you created. One common thing that we get on call a lot is a neurosurgery asks us to get abdominal access for a VP shunt. So what's that? You're doing the same CPT code, the VP shunt. So it's co-surgeons, different specialties doing the same CPT code. Urology calls you to perform lysis for their nephrectomy. In this instance, even though the lysis is necessary to perform the nephrectomy, you're doing it and you're a different specialty, and there is a CPT code for lysis. So totally separate. So you bill as lysis and they bill for nephrectomy, two separate procedures, two separate specialties, altogether separate, no assistant surgeon or co-surgeon on that one. And last example here is you ask a colorectal colleague to help with a difficult portion of a colectomy, and that's assistant. So again, co-surgeon, each surgeon gets 62.5%. Assistant surgeon, the primary surgeon gets 100, and the assisting usually gets around 16%. So just to review again, the CPT is this uniform language of coding for medical services and procedures, and the idea is to streamline reporting accuracy and efficiency. I want to go over general coding rules for multiple procedures, some multiple procedures in colonoscopy, anorectal, and abdominal. So a lot of times, many times we'll do multiple procedures, and we should know that the way that we bill it is usually you want to rank the procedures in descending order by the fee schedule. So you kind of have to know how much each CPT code reimburses by RVUs, and you want to put the highest value RVU first. That way, because you get 100% of that highest valued procedure. And then after that, you add every other procedure that you did, and you get 50% of every other procedure you did through the fifth highest valued procedures. After that, you may or may not get reimbursed for the sixth and subsequent, but many people will continue to pay 50% for that. So first, going over multiple endoscopies. Does that follow the same rule? That does not follow the same rule. There's special rules for endoscopic procedures, and if you do multiple endoscopic procedures, I find endoscopy or the rules for billing of endoscopy particularly confusing, and I actually don't do that much, but I'll go over them for you here because you should at least know that these different rules exist if you're going to be doing the endoscopies. So you want to rank the procedures in descending order by fee schedule and apply appropriate reductions. And what does that mean? So you put the highest value procedure first, but then you add the difference between the next highest and the base procedure. So the base procedure is usually a screening or diagnostic colonoscopy, and I'll go through how you do this. First, just thinking about the difference between, there is a difference, I don't know if you know, but there is a difference in coding, CPT coding for a screening or diagnostic endoscopy versus a therapeutic. And because of that, there's also some insurance differences, and you should be aware of how to code that. So screening in diagnostic endoscopy, the CPT code for this is 45378 versus any number of 5-digit codes from 45379 to 45398 for a therapeutic. And that's because there's lots of different approaches you can take to a therapeutic endoscopy versus just the one for screening and diagnostic. Both of them, you would add a modifier if you can't get to the cecum. If you get past the splenic flexure, but not to the cecum, you add this modifier 53 in the screening and diagnostic and the modifier 52 in a therapeutic. And that's important, especially for the screening and diagnostic, because if you can't get past it, the patient will likely need another scope, and there's some insurance implications of them needing another scope and the insurance company not wanting to bill it again if you don't put this modifier. If you don't get to the splenic flexure, you call it a flexible sigmoidoscopy, and there's different codes for that for the therapeutic as well. So what if you're planning and you got authorized a screening and diagnostic procedure, but you end up performing a polypectomy? You want to select the right code based on what you actually did, and then you add either a 33 or a PT modifier, depending on if the patient has commercial insurance, you use a 33, and then if they have Medicare, you use a PT. Again, this is because you were not planning on doing a treatment here. You were only planning on doing screening. What maneuvers are included in an endoscopy? Anything you do to control the bleeding, any clips, any injections, whatever you have to do to control the bleeding is included in the endoscopy itself. And then if you have to do a fluoroscopy, which I can't think of a lot of reasons that I would use fluoroscopy, but if you have to do a fluoroscopy, unless the code says that it's not included, it is included. Can I bill for multiple codes for the removal of multiple polyps using the same technique? No. So this is kind of a sad one. If there's thousands of polyps, or 10 or 20 polyps, or however many polyps, and you biopsy them all, you don't get any more reimbursement for biopsying more polyps or removing them or anything. The only thing you can do is you can add a modifier 22 statement. Modifier 22 you can use also in surgeries, and you add that statement and you have to say how much longer the procedure took and why the procedure took so much longer. In operative procedures, modifier 22 gets you something like max 20% of the CPT code more. So it's not a huge help, but it is a little more that you can add here if you're doing multiple codes of removing the same technique. Now here's the interesting thing. What if I use multiple methods to remove the polyps? Then can I bill for each method? Yes. Just as long as you used each method on a different polyp. So to get paid for multiple methods, you add this modifier 59 to the codes that are bundled. Bundling is when you use a single CPT code to describe two separate procedures that were performed at the same time. So the endoscopy and the polypectomy, for example. So one polyp is removed using a snare and another polyp is used with cold biopsy forceps. You put the modifier on the 45380 because that's the bundled part, and then the additional code is the one with the snare. Kind of like this is the base code, I guess is how you might think about it. And so you add the 59 to that. What if I perform multiple endoscopic procedures during a screening colonoscopy? Well, your screening colonoscopy code is this 45378 with 3.26 RVUs. You then do a biopsy on a lesion, which you would do this code 45380 with 3.56, a few more bits of an RVU here. And then you also do remove a polyp by a snare, which is even more RVUs, 4.57 from a different part of the colon. This is the important part, is you have to be very clear that it's a different part of the colon. So 45385 is the highest code, so that's the one you list first. You add this modifier 33 to designate that this was a screening colonoscopy, and then you use the next code with a biopsy with a modifier 59 because that's the bundled code, the colonoscopy with a biopsy. So super confusing, but if you're doing endoscopies, you should know how to do this. What if I perform multiple endoscopic procedures during a screening colonoscopy? So this one is screening colonoscopy. Oh, sorry, this is the same question, but we were just looking at how you bill it. So you take the highest code, 4.57, that's that snare, and then the bundled code is this 3.56, and you take the base code away from that. So 3.56 minus 3.26, and ultimately you gain just a little bit more by doing the two different biopsies. But if you're I guess that's, if you're doing a lot of them in a day, then you should get all the RVUs you can. And this is just a chart looking at modifier 59. Modifier 59 is for distinct procedures, different procedures. They are totally separate, but they can be in the same session, and they should be at a different site too. So you have to document those things. Distinct procedure, that it's separate, but during the same session, and also that it's at a different site. This is a big one. Can you do a banding and a flex sig and bill both of them? Yeah, but it's tricky. So you can only do it if the scope is, if this scope is done only for banding and not for diagnostic purposes. So if it's done for a diagnostic purpose, like say you are doing a flex sig because there's bleeding, and the patient also has hemorrhoids, so you're going to band, and you add that 59 modifier because you're checking more proximally to see if there's another reason for rectal bleeding. So it has to be diagnostic. Couldn't be that you're using the scope so that you can do the banding. I don't know if that makes sense, because we don't usually do banding with a scope. But just has to be very clear that your scope is for banding or is for diagnostic purposes. We've had problems here getting this build out. They've told us that you can't, but from a rule standpoint, you should be able to. What if I did an endoscopy in the morning and had to do another one later that day to control the bleeding? Do you bill for the second one? Yes. You bill for the second one. You just have to write that you did it to control the bleeding. You add this other modifier that you returned to the operating room for related procedure, and you get 80% of the CPT code RVUs. That's actually the same for operative cases too. So this one is similar between operative and endoscopy. So this is unplanned. It's related to the first procedure. You don't, you're not out of your global period, and you get the 80% allowable. What if I take them back the next day? Well, your global period is 0 days, so there's no modifier, and you just bill as you usually would. What if I need to repeat the colonoscopy because of a poor prep? This is a modifier 53. And this again is really important that you document this, because if you don't, it's like the earlier one that you couldn't get past the splenic flexure, or you couldn't get to the cecum. By documenting this modifier 53, it allows the insurance to bill again for another, say, screening colonoscopy or another diagnostic. What if you give the moderate sedation? That's totally separate and of endoscopy code, so you should bill for that. I don't know how to bill for that, but if you do that, you really should bill for that. Any questions so far on those things?
One question. So what if you're doing FlexSig in the office during a clinic visit and not in the endoscopy suite? Then how do you bill for that in addition to the clinic visit?
You just like you would for an anoscopy. And again, I've heard from some people that say that they can't get both codes, both the clinic visit code and the procedural code, but we have been able to get it here, and I think it's a modifier 25. I'm not sure if I put it in here later, but by doing modifier 25, we've been able to bill for both the anoscopy or flex sig and the clinic visit.
Thank you.
Anorectal procedures, I think important to know that all abscesses don't bill the same, and this is just, I put this chart here so that you can see the huge difference between just an incision of drainage of an abscess, which is 1.24, and a more complex abscess, which is 6.37. And even though it's probably not a huge difference of your time, that's a pretty good number of RVUs that you don't want to miss out on. So if you're doing these things, you want to make sure to note that you don't just want to put incision of drainage of perianal abscess, because you're going to get this 1.24. That's really low, and so you want to really try and go for, if it's, if you think it's right. Again, you don't want to be doing anything that's false, or doing something that you're just doing to get more reviews. But most of the time, if it's an ischiorectal or perirectal, you just say that and you get the 5.37. if you say intramural, you get 5 point, or intramuscular or submucosa, you get this 5.87. And then if you say ischiorectal or intramural with a fistulotomy or a ceton, then you get this max 6.37. So just be aware of the verbiage that you need to use so that you can maximize. And I would just encourage people not to say that you just incised and drained a perianal abscess, because most of the abscesses that we're draining are more complex, and you should get your appropriate reimbursement for that. Second part to it is I would encourage people to try and not call anything an anorectal exam under anesthesia, because sometimes our billers here were stopping at that and they didn't look at anything else we did, and they call this just a 1.8 RVU. So you can see that almost anything else that you do is going to be more than that. And so I would just say that you place the ceton or remove, incised and drained an intramural abscess or whatever you did, but just drop anorectal exam under anesthesia from it, unless that really all you really did is look, because that's really minimal reimbursement. Although interestingly, more reimbursement than incision and drainage. Oh, here's just what I was explaining. I made a nice highlighted thing to show you that you can really maximize if this is truly what you did. Abdominal procedures. How much time do we have? We're getting long here. Abdominal.
We have what? 15 more minutes. Okay.
So the tricky thing is that in abdominal procedures, a lot of independent codes are already included, and at least colorectal codes, and not billable as independent.
Dr. Lopez, sorry to interrupt. We did have one question.
Oh, sure.
Going back to the anal rectal RVUs.
Yeah.
So Dr. Cunningham had a clarifying question if the 46060, so that last code, do you does it necessitate doing the fistulotomy or fistulectomy, or would drainage with description of like an ischiorectal or intramural abscess be sufficient?
I think you have to do a fistulotomy or fistulectomy, because otherwise it would be this 460. Is that ischiorectal intramural with, yeah, this is with, and then you can do with or without a ceton on this one. So yes, but I think at least in my idea of things, I oftentimes do a partial fistulotomy to just open up the more lateral part of the tract, so it's shorter tract. I don't know. I don't think it's hard to get this code if that's what you're kind of concerned about.
Thank you.
So in abdominal colorectal codes, as I was saying, these codes here, XLAP, diagnostic lab, lysis of adhesions, repair partial resection of the omentum, and mesentery repair. These codes, if they are the only thing that you do, you can bill for them, but they're all included in any colorectal procedure that you do. So you can't bill for these in addition to your colectomy or whatever you're doing, colostomy, takedown, whatever. These things down here are already included. So nerve monitoring is included. Any sort of imaging that you might do included. Tap blocks, on-cue pain pumps included. Hepatic flexure mobilization, endoscopy to assess landmarks, tattoo, identify lesions, assess anastomosis, ICG, and omental flaps to buttress or repair. All those things are included in the colorectal abdominal codes. So you can't bill for them separately. You might want to say that you still did them in your operative note, but they're not billable. So what's not included that you should bill for extra? Mobilization of the splenic flexure, and that comes in both open and laparoscopic forms. Other procedures on different areas of the colon. Say you do a right hemicolectomy and a sigmoid colectomy for different reasons, then, or for obviously you're taking them out for different reasons, but those you can both bill for. Anything that you're doing to the small bowel or other organs, billable. And then omental flap is billable if you're using it to fill a defect, but you have to be very clear that you're using it to fill a defect. So if you're doing an omental flap to fill the pelvis after an APR, that is billable. So you have a 50-year-old female with a mid-rectal adenocarcinoma. You did a robotic resection with a colorectal anastomosis and loop ileostomy. How do you code that? Let's see. So what qualifies as a low pelvic anastomosis? So just looking here between a colectomy with a with partial with anastomosis versus the low pelvic anastomosis, you can see that the RVU differences are pretty significant. Well, there's not a clear CPD definition of what a low pelvic anastomosis is. You have to make that clinical decision. Some people say that if you're using an EEA stapler, then that's low pelvic anastomosis. Some people say that it's below the peritoneal, anterior peritoneal reflection. There isn't a clear definition. You just have to be clear in your documentation that you think that you've performed this low pelvic anastomosis. So if you want to be very sort of clear about it to your billers, you would say exactly this, that we performed a low pelvic anastomosis. So we did robotic resection. Generally that falls under laparoscopic. There is a modifier for robotic, which I think is not totally necessary to use, but it's there. I don't even think I put it here because we just use the laparoscopic code. And then with a colorectal anastomosis and a loop ileostomy, but you can see out of these codes that there is not a code with an ileostomy, and actually it is the same as a colostomy, and so you bill for it as with a low pelvic anastomosis and a colostomy the same, even though clearly we know that a colostomy is not the same as an ileostomy. So what if it's partial colectomy with a loop ileostomy? So then you go for this partial, and your loop ileostomy is totally separate. So how do you bill for that? The partial colectomy has more RVUs, so you list that first, and you get 100% of this 26.42. The second procedure is the loop ileostomy, that's 44187. You modify it with a 51 because it's a multiple procedures, and you get 50% of that 17.4. So it's 8.7. What if I did a splenic flexure mobilization? This one, because it's, I think the way it works is just because by definition it's an additional procedure, you actually get the 100% of it. So it's 44213. Again, different codes for lap versus open. And then what if I did extensive lysis adhesions? Can you bill the lysis adhesion CPT? No, because that's included. And again, included in any colorectal procedure that you do is lysis adhesions. But if it took you 2 extra hours, you should get at least a bill a tiny bit for it. And so you get that modifier 22. And you put that whatever you think that you had to do that made it harder. So for me, I think probably lysis adhesions made both a partial colectomy and a splenic flexure mobilization harder. So I would add the 22 to each of those. But you can add it to whatever part is harder. You just have to document that. And usually I document it in my findings, or you can document it. I suppose you can document it in the main body, but I usually document it in my findings, and I say something like, modifier 22 just directly, and I say this case was increase in complexity due to significant and dense abdominal adhesions associated with multiple prior procedures and radiation, or history of intra-abdominal sepsis, or whatever you want to put there. But you have to explain why it was harder, and then you should say something like, this resulted in spending significantly more time, and you can even put in there how many more hours it took you to do such a thing. So if I spent 2 hours lysing adhesions, that's a place where you would list that. But it just helps support your claim that this was increased in complexity. So going back to that modifier 51, again, we added that to the loop ileostomy. That's any time that you're doing a multiple procedure. It's something else that you did at the same session during the same index operation, and it's at a different site. I would say check with your compliance people, but this is one that we get pretty regularly, and we've been able to bill it. And so ureterolysis, it's a pretty good reimbursing CPT code. It's 20.64. It's a different site and a different diagnosis. So the separate diagnosis that you have to bill is retroperitoneal fibrosis. And that can be from prior surgery, it can be from prior radiation. It doesn't matter what it's from, but we often operate in the setting of retroperitoneal fibrosis, but you just have to list it as another diagnosis. So that's modifier 59, different diagnosis, has to be listed as retroperitoneal fibrosis, and you get this ureterolysis in the setting of retroperitoneal fibrosis. If you did ureterolysis and there isn't, so you do the ureterolysis, but there's not fibrosis, it's just an easy dissection, that's just part of your normal operation because you don't have a second diagnosis. This can be bilateral. And so you get 150% of 20.64. So you get 30 RVUs for this. So that's pretty significant. And the modifier for bilateral is 50. So this is again modifier 59. It's a distinct procedure in a different site, and it's a different diagnosis. That's all I've got. Questions? That's a ton of information and kind of boring and hard to follow because a lot of you haven't done or heard any of it, but hopefully you at least kind of get the hang of what types of things to look out for. I don't know.
No, thank you so much, Dr. Lopez. So you're right. This is not taught in really in most programs. So even just having an overview and a reference for us to refer to once we do start our practice was really helpful. And I know I'll be referring back to it very soon. So I don't see any more questions on Surgeon. But if there are any, I'll reach out to you and we can respond on your behalf. So
Awesome.
thank you. Thank you again for joining us.
Thanks for having me.